a podcast by respiratory leaders for respiratory leaders. This is RT Sidebar. Stay tuned.
All right, Barflies, we have an interesting snack today. JB and I were just hanging out and we were talking about what is an interesting topic on RT Sidebar. Just do a little snack, a little bite-sized portion. And we were combing through respiratory therapy break room, which is pure genius. Mm-hmm. And one of the top contributors an hour ago posted giving report to an RT I've never met versus giving it to my favorite night shift RT. And they're like, yeah, it's so much different. But we started talking about report and report can get interesting, as an RT, report's interesting. JB, you're in California. I'm in Pennsylvania. I bet you report's not that consistent no matter where you are.
And report's such an interesting topic on what's good report, what's bad report. I feel like it depends on the person you ask, and then it could get heated. I mean, should we add a report as one of those things that you don't talk to? It's like religion, politics, report, because no matter what, you're going to be wrong and get punched in the eye. I mean, it's a hot topic. What's good report? What's bad report? And, you always assume the report that you give is the perfect report that can't get any better. But is it really? Because it's
if you ask any RT if they give crappy report, the answer is no. I give a good report. How often do you really get good report?
Exactly. It's no, I don't give good report. I give the best report. I don't give too much. I don't give too little. Everything I say is perfect. Yeah, it's not.
It's not. So when we were chatting, we even brought my wife in, Heather, who's an RT, to give us some thoughts about her report. I want to start with a story of a colleague that we used to make fun of because she used to give very long reports. So Debbie, you know who you are. Debbie, you'd sit there and go, oh my God, this is the longest report ever. And too long is not good. Too short might be worse. But every once in a while, she'd have a tidbit where she was talking about a daughter and you'd walk in and go, oh, I know that daughter. I want to go that way. So there was always this little tidbit of information that you need. So the first conversation I want to have is when it comes to crappy report, too long versus too short. Where's that sweet spot?
I guess when you start getting, and this again, this is my opinion, because everybody's going to be different on this.
Yeah, because your report is fantastic.
Yeah. Everything I say is perfect. You can't get better than that. I wish I could do the Trump impersonation when I say that. No, I mean, once you start getting outside of useful information, then it's and you're in the weeds, it's a little bit much. And we used to tease those people and be like, oh, okay, so what did the patient have for breakfast? Did they have enough bowel movements today? And this is only for my BID MDI, so
oh, exactly right.
So when you start getting into the weeds on stuff and it's not useful information, it's really not helpful. But like what you just kind of mentioned, if there's a family member that's going to attack you when you come in, and they're going to say that either they're a nurse or in the healthcare industry, or a very close relative is, and they said everything you are doing is wrong, and they question you. Yeah, I'd like to know that. That's not part of the Q6 treatment that I'm about to give. But if I see them in there, I might give them last and hope that the the visiting hours are up prior to me going back in there to give that treatment. That's
We've
good
all
stuff.
been there.
That's good stuff. Good stuff to know. And that's not pertinent to the treatment, but those are good things. But yeah, again, when you get to the nitty gritty of stuff that is not pertinent and will not change the therapy I provide in any sort of the way, then it's a little bit much. But I mean, Matt, what would you consider to be overkill?
overkill is anything that's not going to help me deliver care. That's the way I look at it. So, like we talked about patients that are like chronic vents, like we've known them for like a year. Don't give me the history. Like we've all taken care of this person. That's way overboard. Um, but the social stuff, sometimes I do want to know because I don't. I can wait till after visitors hours. That's fine. Um, if they're a board member, I probably want to know. But
Yeah.
I also, I think sometimes we get kind of our goggles on, right? We're respiratory therapy. I'm going to give a respiratory therapy report. Don't read the damn thing to me. Like I can see that they're on my favorite drug, Duaneb Q6. I can see that. Please don't review that. But, sometimes, hey, they had breakfast and they had too many hash browns and their salt went up. I don't care about that. But I do care about the things that are like when I walk in that door, I don't want a surprise.
Yeah.
Because have you ever had beeper report? We used to call that beeper report, where your report is literally a beeper sitting there on the counter for you. That was beeper report.
I think I said
Have you had
beeper
one
for
that's
a
too
second.
short?
Now that makes sense. No.
Yes.
Yeah.
Yes.
No,
Huh?
I worked in a department and there was quite a few people, and report was same old, have a good shift. And that was it. Yeah.
They drop the mic and they're gone. Like,
Yeah.
and then they're just there. And then have you ever had a report where it's beeper report and then you go to pick up your phone and there's like 15 missed calls or 15 missed beeps? You're like, oh my God. That is the worst. Like, why were you waiting? Well, we know why you were waiting. So, um,
I got a
how
story
much?
though for
No,
the
please.
this is for bad report. And I don't know if I've mentioned this story before or in the past, but it's one that'll and luckily it's from a second person, so I didn't have to live through this mortifying event. But yeah, it was stemming from bad report. So it was a step down unit, and I was the night shift coordinator at the time, and I had a new
Okay.
grad. And he walks into my office, and he is as pale as a sheet. And he's normally a dark complexion kind of guy. And so when he starts matching my skin color, I'm like, oh shit, what's going on?
Hmm.
And he was
Yeah.
like, he's like, can I sit down? I was like, yeah, sure. So he sits down, and he says, I went to go give a breathing treatment. It was like a Q6 treatment. And, I went in and because we don't normally get labor and delivery patients in step down. It's just
Yeah.
unusual unless you were going to have like an Increta event or something where, they
Hmm.
needed some kind of surveillance or whatever, not surveillance, observation.
Hmm.
So he goes in and yeah, it was a labor and delivery. They got all the balloons, the family's in there, the crib is in there, and then the treatment was because the mom was an asthmatic.
Okay.
So he goes in there and he does, the obligatory stops by the cradle and was like, Gucci, Gucci, go. So it's such a cute baby, this and that, right? And so he's like talking to the baby, and then he goes and like the family's just staring at him, and no one's talking to him. So he wasn't sure if there's like a language barrier. So he's like trying to describe
Hmm.
the treatment. He's like, as from being an asthmatic, you would think that they would understand the treatment. So he's like explaining the treatment, and he gives her the treatment, and everyone's just staring at him. And then he tried talking to him, and then he just left, right? And he's like, that was just an unusual event. Like, I'm not
Hmm.
sure if
Just odd
they don't
encounter.
speak English or something.
Hmm.
So then he goes to the nurse's station and says, hey, by the way, I just went and gave a treatment to that bed over there. Did the baby need anything? Because, do they need oxygen or vitals checked or anything like that? And the
Hmm.
nurse looks at him and goes, what are you talking about? That baby's dead. It was a stillborn baby. And yeah,
Oh
that
my
baby's dead.
God.
But he's over there in the crib, like coochie coochie coochie. Oh, you're such a cute little
Oh my
baby.
God.
And then that's why the family was just mortified and looking at him. It wasn't a language barrier. They're like, you're talking to our dead, child,
Oh,
grandchild, and he was just beside himself. No one
mortified.
like in reports that would be good information to know, right? Like you don't go and do that. You just go and focus on the
Oh
patient
my God.
and pretend that that's not an incident that happened, right? But yeah, no, bad report. No one told him about that. And so, yeah, he made himself
Oh
to
my
look like an
God.
idiot.
I don't have a story that's that bad. But I used to be a neopeds guy, and I had the peds floor for the day, and I got really no report other than there was a 12-year-old that was ordered breathing treatments. Her breath sounds are clear. I don't know why they're on breathing treatments, and I'm like, okay, that's kind of odd. I walk in the door, she's in a diabetic coma. She's in full respiratory distress. I can't wake her up, and I'm
What was the
like,
report on this
that
patient?
they would have clear breath sounds. Like, I'm like, so we end up having to intubate her, blood get like as soon as I walked in the door, I had to call rapid. I'm like, oh my God, what the hell is going on here? So like I feel, and when we talked to Heather about it, there are things that are important to know, and there are things that are not important.
Yeah.
I'd like to know that the patient's about ready to code. That would make me happy, or
Yeah.
that there might be some type of social issue, or you have a stillborn baby. Like that's horrible.
Yeah.
Oh my God. Oh my
Yeah.
God. Do you think that there is do you think that people in IC like when you're in ICU or the floor, do you think report changes?
You know, I've been thinking about that. We were throughout the years have tried to standardize report, and
Yeah.
there is no standardization across all patient populations. And then you can if you tried to standardize it, you'd create a piece of paper and you'd have all these check boxes, but they're not going to be applicable to every single patient. And then you
Mm-hmm.
might end up, and then once you get people turned off to it, they're just not going to use it. But I think coming at it from an acuity based report would make more
Mm-hmm.
sense, right? So a BID, MDI versus a ventilator are obviously going to be two different reports, two different requirements. Um, but even amongst the floors, right? So med surge dry powder inhaler versus a telemetry Q4, Q6 treatment.
That could
Those
potentially go to
those
the
could be two
ICU.
exactly. Those could be two different reports too. But again, those are two different acuities, right? So then, what does that look like, and how would you be able to get everyone on that same page?
So have you, we both been directors. Have you ever tried to standardize or been in a place that tried to standardize? And how did it go?
It fell flat across the board. As a director, I couldn't do it because then, I had like 115 RTs, and trying to get them to
Mhm.
do anything was ridiculous. And then I've been staff in, departments that were 60 to 80 people. And then, it's very opinion based. And then if they don't believe in it or they just don't want to use it and it's awkward and it's change, it just falls flat. So I still haven't seen it successfully done.
Mhm.
Um, but if any of our listeners have, we'd like to hear about it and we can talk about it
Absolutely.
later in the show. So yeah, feel free to add a note to this show. But yeah, I haven't had it work. Have you had it work?
Um, no, uh, to be honest, absolutely not. When I was working down in North Carolina, we tried to do bedside report. That did not go over well at all because I was at a children's hospital. They're like, so you want us to walk in and have a full conversation with a child that's asleep? I'm like, yeah, you're right. I'm sorry I even brought it up.
Yeah.
It makes sense. I actually saw a meme recently that said, "Do you really want to have bedside report and wake up the patient at 6:30 in the morning?" And they're like, they're sick. Let them sleep. I'm like, duh. So I've seen it tried. The closest I thought that we ever got to good standardization is I worked at where Heather and I met. We had like a clipboard that had like a grid on it, and you could write out report. Okay. And everybody kind of knew what to expect. You can overdo it, you can underdo it, but it narrowed the gap a little bit. I thought it did at least because everybody started to have some type of expectation.
Yeah, there's some EMRs now, like Epic, for
Hmm.
example. So it's the last one I've used. And what they have in there, which I find interesting and useful, is they have sticky notes. And they have sticky notes that are
Yes.
on the chart, and you can be either sticky notes to the providers or sticky notes to your peers. And then you can just write down little comments and stuff that'll kind of carry on with that patient, which I find to be
Hmm.
helpful if there's good tidbits of information. Don't overdo it again. But yeah, I find that to be useful. But
So,
one
yeah,
one
go
thing
ahead.
though, I have to add to your bedside report. I think bedside report does work, but you have to have a certain level of emotional intelligence, right? And so one being what you just said, right? You don't go in there and start blah 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 and wake everyone up because most likely
Hmm.
being a peds hospital, you're going to have the parents in the room. Then now, are you worried about dropping information that yet hasn't yet got to the parents, and then now they're in an uproar, like, wait, this is the first I'm hearing about it, and then you get all that stuff,
Hmm.
right? But can you have that low voice conversation um, outside the room? Then both are aware, okay, we had the conversation. Now go in, keep your mouth shut, just poke around, look at the tube, look at the vent settings, and then come back out and then continue the conversation outside.
That's what we tried to do. Okay, go in. Here are the important things you need to know. So whether it's nursing, this IV is about ready to run
Hmm.
dry, blah blah blah, and then they should come back to right outside the door and finish report. I thought that was probably the best move, because waking a sick kid, yeah, don't ever do that.
Oh,
Ever do
and yeah.
that.
Or another pet peeve I have in the situation is the people that want to go in there and it's dark and they flip on all the lights.
Oh
I
my God.
cannot tell you how cringe that is. Like I when I see the patients like squinting and they're upset and then they're startled and then you get the family members waking up in the back on the bench like that's just the worst. And I worked night shift for many, many, many years, over 10
Hmm.
years. I would
Hmm.
give treatments in the complete dark, and the patients would offer, like, do you want me to turn on the light? And I said, no, I mean, your eyes are gonna be fried if I
Hmm.
turn on all the lights. I can see enough where I can do it. I've even seen some nurses and RTs with like little lights on their badges
Little
and
flat.
stuff so they can
Hmm.
work
Little
in like a
flashlight.
low light
Hmm.
situation. But yeah, you want to like piss some people off. You flip on all the lights or like shine lights in
Exactly.
their face. Jeez. Yeah.
So it sounds like right now there really is no good solution.
No.
It's going to be hard to get everybody on there. My concern is, and you were quality risk and safety for a long time. Isn't communication like usually the number one reason for a safety event?
It is, but then it's got to be good communication, right? And
Yeah.
so report is all about communication. Bad report stems from lack of communication,
Hmm.
but you can also have a bad report from overabundance of communication, where you're talking about stuff that's not applicable. Because then what ends up happening is people tune you out, and now they're not listening to anything, and now you're missing out. And so, did you do your due diligence and say everything under the sun? You did, but you also turned off the recipient that's supposed to be listening to you. So really, if you can get back to the S bar, just
Hmm.
situation, background, assessment, recommendation, and very quick to the point and pertinent information, you'll probably be successful. But what is pertinent is going to be subjective to the listener. So
I mean, it is. It's not really what comes out of your mouth is what goes in their ear, right?
yeah.
So, do you think I have found that report can also, if you listen to report as a leader, sometimes you can find out some education gaps. That's something you brought up to me before. Have you noticed that? Because I've noticed it. I'm like sitting there listening to report. I'm going, you're kind of missing the boat here with what's going on in that patient. Any final thoughts on that?
Yeah, that is that's an excellent point. The like I would say about RTs or nurses or even physicians is that not one RT, RN, or MD is created equal. The
Mhm.
level of education and experience is going to vary, but if you're going to try to up the baseline of knowledge, then listen out for those things, right? So,
Mhm.
like what was mentioned earlier, with certain levels of PEEP, tanking, the blood pressure,
The blood pressure.
if that wasn't common knowledge within your department, start looking for those things, right? So then you can actually pick that up in a report, because if you wait for an RT to put that in the comment box that's covered in dust and spider webs, good luck, right? But if you're there at
Yeah.
report and you hear those things, you can pick up on those cues. And if you were to tell me that, like, oh, if this certain PEEP under these certain conditions drops the blood pressure, and I have a puzzled look on my face, then I'd probably jot that down, work with my educators, and come up
Mhm.
with an education plan. And because if that one person's confused, most likely there's a lot of people that are confused. So let's have that as an education plan that goes out to everyone. And then you
I
kind
like
of
that.
get that baseline to go up a little bit, and get everyone on the same page. Because then now, um, if you educated one RT and then now they're out looking for this specific patient and managing the PEEP in a certain way,
Mhm.
now you get everyone looking for that. And that's the glory behind management, is that you're improving patient care through the collective of your team that you're the head of, right? And that's how you do
Exactly
it.
right.
So, I mean, what would you
Well,
do?
that's what I would do. I mean, listen, be present. Like, if you're a leader that really cares about quality, safety, and their people, you can't be sitting in your golden palace. You just can't.
Yeah.
You got to get out there. You got to listen. You got to understand what they're going through. And if you want to sit behind a spreadsheet or behind a closed door, maybe you shouldn't be a leader, especially today. I think that
Yeah.
you got to listen to your team and understand what they went through. But report is report. I'll never forget report. I've been away from the bedside for a long time, but I'll never forget it. JB, we're gonna finish up right now. This is a great little snack. What we're gonna do, we're gonna publish this in the Barfly group as well, so we can get maybe some feedback. And maybe if there's
All
anything
right.
good, we'll give some shout outs when everybody has any feedback. So any shout outs for you today?
Um, no one is specific, but I just always revert back to the RT break room or any of the respiratory chat rooms,
Mm-hmm.
because I get a lot of our community's feelings through those groups, and then it allows us to talk about it here. So
I
keep
love
up
it.
the good work, and keep voicing your opinions. You may not think anyone's listening, but Matt and I are.
Yeah, absolutely. And shout out to Anthony, who actually put this on our team break room. While we've been sitting here, he's gotten 133 likes
Wow.
just in 20 minutes. So well done, Anthony. Thank you for bringing
Yeah.
that up to
Good
us.
job.
The only other shout I have is check out Mindy Conklin's episode at the OSRC. It's fantastic. Always keep an eye out for RT Sidebar, the RT Sidebar Barfly group on LinkedIn. Join, be there or be square. Anything else before we go, my friend?
Yeah. Stay
Hey,
tuned.
tuned.
Vapotherm does not practice medicine or provide medical services or advice. Any clinical recommendations provided herein are solely those of the speaker. Practitioners should refer to the full indications for use and operating instructions of any products referenced before use. Pavlichko and Hayes are employees of Vapotherm. Butler is a paid consultant, and our guest is not compensated.